Okay, thank you very much. Of course, I'd like to thank the organizers for the invitation. It's a much quicker journey now that I only live in Innsbruck rather than from the UK or from the United States. The question I got asked to talk about was the MRI and the insights into the pathophysiology of cerebral forms of mountain sickness, and I put a little question mark there myself because I'm not sure whether it has given us many insights or more questions than it has answers, and hopefully I'll describe some of them today. So my task, I'll try to give you some pathology of the cerebral forms of mountain sickness, some of the MRI findings and the interpretation, and I'll tell you a little bit about what these non-invasive MRI findings tell us when we actually do some more invasive pressure measurements, and then we'll just one slide or so on some future avenues of research. Okay, so the neurological symptoms of acute mountain sickness are typically from, they call it high altitude headache, and you can have that stand alone if you want as a typically frontal, bilateral, and dull headache, but that is by no means a universal finding. It's quite variable, but I'd say 60% or so, and I've measured it and others, seem to find this frontal headache. Then you move on to mountain sickness, which is this combination of symptoms now, so non-specific symptoms when you add on fatigue, nausea, dizziness, and sleep disturbances. And then, of course, there's HACE, which is high-altitude cerebral edema, and I've marked this as a continuum, but there's, of course, controversy whether this is a continuum, and I'm not sure if it is, at least in symptoms, perhaps in physiology, but not as in this is a progression from this. I'm not sure if that's the case. Because at least in this part, at least the headache especially, and perhaps the headache causes some of these other symptoms, is predominantly due to trigeminal vascular activation. That is the mechanism of how you develop a headache. And this is from the trigeminal nerve and through to the vasculature. So, of course, it's the combination of these two words, trigeminal and vasculature. And I'll show you later on really how beautiful this system is and how what we call it is somatically selective. And you can stimulate these arteries and veins, and you get where you get the headache is very relevant to where you stimulate what arteries and veins and pain-sensitive structures in the brain. And, of course, HACE is a completely different beast where it's defined by its name. You have to have brain water, extra water on the brain, so cerebral edema. So they are quite different. And I think really importantly, and it's going to contrast a little bit what Peter said, I guess, but what's really important is when we take measurements and when the symptoms occur, and of course that has also been described in the talk only 2 moments ago. And if you plot headache over time, only over 12 hours, you can see the headache is already quite pronounced by 3 to 6 hours. This scale doesn't really do it justice because out of 3, well, 2 is 50%, so 50% out of 100 is quite a severe headache. I can assure you from anyone I've measured it, really a 1 does not give this justice of how severe a headache you have with a 1. It's really 33% out of 100, so it's quite severe even within 3 to 6 hours. And these other symptoms, nausea comes on a little bit later. Again, it's normally, in my experience, most times after the headache, not before, although you can have some people who get nausea early on. And then the other symptoms are quite non-specific, and they sort of peruse around in the low levels. If I plot some other data, this is unpublished data from my thesis a long time ago. You see, this is the mean data. What Martin Butcher did a long time ago, recently, is they split it into non-affected, moderate, and severe. And you can see if you mean this data, it's about the same. Also, from Chris Imre and Mark Wilson's group, about the same over the same sort of time course. And if you go a little bit further, so into, I think, 22 hours, the headache doesn't really get much worse. So around about 12 hours or so. And if I just go from another study from Damien Bailey and his group and Peter Bartsch, you can see that it's about the same. So if you measure mountain sickness, Lake Louise questionnaire, the environmental symptom questionnaire, or headache alone, predominantly the most severe symptoms occur around 8 to 15 hours. So of course, the actual pathology must have occurred way before that. So what if you take a measurement of any pathology here or even here, it is a combination of pathology plus feed-forward mechanisms and everything else that goes on once you have nausea. The actual pathology could have occurred, if I go back, all the way back here at 3 hours because the headache's already on. So it's very complicated, and perhaps I agree you might want to make measurements very early on in the hypoxic exposure, not very late, and that is, again, contentious, of course, but it's my belief. So I'm going to give you a little overview of the proposed pathophysiology. This is quite a volumetric-centered pathology, so it's one more towards brain volume or, of course, dilation of the vessels, but there are other hypotheses, of course. So as you become hypoxic, you have arterial and venous dilation, and it changes in blood pressure, and independent of anything else, this could cause trigeminal vascular activation headaches. You do not need any changes in pressure, no vascular, no inflammation. This could be the only mechanism that is required. So remember, this is a long, long list, and it could have all have occurred just here. But of course, with an increase in blood flow, you have increase in brain blood volume. This could lead to an increase in intracranial pressure. That then can also activate the trigeminal vascular system via compression of these trigeminal vascular nerves. But of course, if ICP goes up, eventually, because ICP is high relative to the sagittal sinus pressure, you should just, eventually ICP should come down because your CSF will move out of the brain and completely compensate for any volume changes, and you end up with a normal intracranial pressure, unless you have some form of stenosis or a compression of the veins, because what controls intracranial pressure over long term is the pressure in the sagittal sinus. So if you have a compression here, you have a high sagittal sinus pressure, will have a high ICP, and this will precipitate forever. As long as the sagittal sinus pressure is high, you'll have a high mean intracranial pressure. But let's say it doesn't. Let's say ICP goes to normal. You now have a normal ICP, but of course you could be on really the steep part of the curve, and then with any sort of transient changes, Valsalvas, exercise, hypotension, or sleep apnea, you have these transient changes in ICP, which can cause trigeminal vascular activation. These can unfortunately feed forward back to blood pressure oscillations, which you commonly see in hypoxia, which leads to these stretching and distension of the arterial veins, and of course this can then lead to disruption of the blood-brain barrier. Unfortunately, it goes on with many, many links for overexpression of cortical-releasing factors, a whole hypothesis with inflammation and VEGF, and of course, unfortunately, this could all cause mountain sickness and a headache independent of any of these things. So it's very, very complicated. And of course, what is a problem is once you get a headache, you then have local release of local vasodilatory factors within the trigeminal vascular system that further leads to vasodilation in the brain and further compounds the headache. And what no one ever talks about, which is even probably worse, is that these substances, and at baseline, you have a completely different changes in the sensitization of this system. All systems have a range. All systems have a sensitivity. And these systems, and they've showed this at least in headache models, that as you get more and more release of these vasodilatory factors, for any given pressure on the vessels, you have more nerve firing. So you have a more sensitive system the longer you're in hypoxia. So the headache could get more and more severe over time, not because of any physiological mechanism like an increase in brain blood flow, but just because you're getting more and more sensitized to that sensation. So a really, really complicated model. And I'm just going to talk a little bit about what this part, at least the MRI and some other measurements has led us to believe about the brain in hypoxia. So this is the cranial space, and within the cranium you have the brain itself, the parenchyma, both gray and white matter. You have, of course, cerebral spinal fluid, you have arterial volume, and you have venous volume. We know they have, of course, arterial inflow and venous outflow. And the question is, of course, we've measured many times. They have an I'll tell you, of course, you have arterial blood pressure, intracranial pressure, and then sagittal sinus pressure, the three pressures across the brain. So we know that blood-brain flow goes up when you become hypoxic. So the question is there an increase in arterial volume in the brain or an increase in venous volume in the brain? And the way we can look at that in some way is using MRI. So we can actually take very nice pictures of the brain. We can segment it using some algorithm techniques to extract the skull. Then you can use some techniques to say, okay, this is white matter, this is gray matter, and the blue bit is cerebral spinal fluid. So we can separate the different volumes of the brain. I'm just going to show you the sort of a summary of at least most of the brain volume imaging studies. And you can see there's highly variable, and if you want some questions, we can talk about why there is some variability. But in general, there's consensus, there's an increase in the volume of the brain. At least, of course, we're not making any new neurons, the brain's not getting bigger, so this must be either blood or it must be water. So is there a point where the brain does compensate? Does it shift CSF out of the brain? We can also measure that also via MRI. So we're saying this one goes up, and then we're moving CSF now out of the brain, both into the spinal canal and into the venous system. Same technique with MRI, and again, it's quite a universal finding, as a mean at least, between studies, that there is a shift of blood out of the brain somewhere, so either into the spinal canal or slowly over time into the venous vasculature. But the question is, okay, we're now measuring brain volume, but is that blood or is it water? And that is quite a contentious issue, because of course, if brain volume increases further with brain edema, and you cannot compensate with a decrease in more cerebral spinal fluid, ICP will go up in the end. So what we do know, at least, I think, and this is just an image from a study I did a number of years ago, and actually I only took this one because it was easily available to me, but it had been done before me, and it's been shown many, many times afterwards that there's a decrease in what we call the apparent diffusion coefficient of the water. So basically, there's a change in the diffusion of water within the white matter. But in my opinion, the problem is that it's so often seen. Everyone sees it in every study. It's not really related to mountain sickness, perhaps in some correlations, but it really, is this a pathological mechanism or just an adaptive phenotype, or is it perhaps just a consequence of hypoxia that we're just measuring and it means nothing to do with mountain sickness? But we always see it, this change in this apparent diffusion coefficient measurement in the white matter. But how about brain edema? Well, in my opinion also, there's no even really statistically elevated measurements of brain edema. Of course, in haste, you can see it. You don't need an MRI, you don't need fancy statistical tools. There is water in the corpus callosum. And this really is the gold standard measurement of water in the brain with MRI, so a multi-echo phase decaying T2 relaxation time. And for the studies that I can find that have measured either the multi-phase or a single T2 decay, there's no statistical increases in brain water in the brain of any patients with mountain sickness over 10 or 22 hours. Now, of course, there is some individual variability, and you can correlate things. And of course, if you perhaps squint one eye and turn your head a little bit to the left, you can convince yourself there's a correlation here, maybe. But really, it's being driven by these low values and a couple of high values. Now, what I will say is this measurement is really, really very reliable. We took this measurement twice at sea level, and you do not expect these changes. So perhaps there are some individuals who have some more brain water on the brain. And of course, haste is rare, so they're rare cases. And a recent study really did a really nice job of this, doing multiple measurements over time, and I'm going to not do them justice at all by showing just one measurement. But this is from Chris Imray and Mark Wilson's group in the UK, and you can see now that they're seeing quite a large increase in white matter after 22 hours in hypoxia. Now, we don't know whether that's blood or water because it's just measuring a volume, but really the blood flow in the white matter is quite low, and there's no real reason to believe it is elevated, so we can suspect that actually after long periods in hypoxia, 22 hours or so, we are beginning to see now some increases in brain water. And again, there's this, I guess, vague correlation between how big the brain white matter gets and how sick the people feel. But at least my take-home message is that there's no visual evidence of brain edema or microhemorrhages in any study that I've ever done or I've ever seen where we can clearly see in brain water. So I remain quite skeptical that we have a working model of haste in healthy humans in acute hypoxic models. So how about the intracranial pressure? Of course, we are seeing these volume changes, but so do we actually see any changes in intracranial pressure? The MRI doesn't really give us any insight into that. There is a non-invasive technique that I've used also, but it's as susceptible to non-invasive techniques as any other non-invasive technique is. But what we will see, so I'll give you an example of what you should see. So as brain volume increases over time, you should see ICP not change at all very much because you have this spatial compensatory capacity. We call this the static spatial compensation curve. Whoops, sorry. But then if you have an increase in brain volume beyond the spatial compensation, you can have an increase in intracranial pressure. But of course, because ICP is high, now the ICP sagittal sinus ratio is much higher, so you have a greater CSF outflow. CSF outflow comes into the venous system, and ICP should trickle back down to normal, and we should just be just fine. However, again, the difference is, like I told you in that model, is if you see a collapse in this some form of the outflow tract, then you'll have a pressure gradient across here, and ICP will be high. And we have seen this in at least one MRI study where the person, and most people, start off with these very small transverse sinus, and it disappeared later on. And this could be an artifact of the MRI technique, but at least we did see it in a few subjects in one of our MRI studies. And this is an angiography study showing how this actually works and how the ICP basically drives this collapse of this transverse sinus. So here they put a catheter along the transverse sinus. You see it is collapsed, it's a stenosis, and the pressure gradient now it should be 10, but because of the collapse, the pressure now is 29. The pressure is 30, so the ICP must be above 30, because this ICP must be above sagittal sinus pressure to maintain outflow of CSF. You do a lumbar puncture, you remove CSF, you lower the ICP, and lo and behold, the stenosis goes away, and now the ICP would be normal. So it is a completely feasible physiological mechanism of how ICP could remain high constantly, perhaps in someone with brain edema, for example, at altitude. So what are the consequences for intracranial pressure? Oh, check the time. Fine. This is a study done by, again, Damien and Peter a long time ago now, and they used lumbar puncture and normoxia, and after 16 hours of hypoxia, and they showed that the pressure in the brain was completely normal over time. If you split this into non-AMS and AMS subjects, there's no difference. So there's no, again, it's showing you that over time, most likely the spatial compensatory capacity is working in the brain, it's completely fine, at least on all these subject level, group level. But remember, there's a lot of time in between normoxia and 16 hours of hypoxia that a spot measurement doesn't tell you. If you measure blood pressure, a one single cuff measurement in 2 time points might not give you the whole story. So I'm going to give you a little bit, just some unpublished data from my time in Ben Levine's lab in Dallas. And classic Levine style, when I told him about measuring intracranial pressure, he told me, I don't care about your nonsense, non-invasive measurements. If pressure is your outcome measure, you've got to put a catheter in it. So we found a couple of patients, a lot of them actually in the end, who have this Amaya reservoir. And they had it placed there for a prophylactic chemotherapy many, many years ago. And we recruit them, well, a minimum of 3 years, but normally 10, 20 years after the insertion of this Amaya reservoir. And I'm going to show you just some invasive data from 3 subjects we did in Ben's hyperbaric chamber. And the aim was to do 24 hours in all of them. And you'll see why many of them perhaps didn't make 24 hours. Just the first subject, and perhaps one of the most striking findings also, it's commonly well known, but many of you might not know this. This is the ICP, so it's saturation in green, ICP in purple, arterial blood pressure from the phenometer, and transcranial Doppler, so brain blood flow. And you can see that just by simply going from the upright to supine posture, ICP is wildly different. This is normal hydrostatic gradients, just going from the upright to the supine position on Earth. And what many of you might be thinking to yourself now, as I thought to myself, is, well, clearly the absolute intracranial pressure cannot give you mountain sickness, because I can give someone mountain sickness sitting up all day long, and the pressure in the brain is 0. So clearly it cannot be the mean ICP. It just cannot. But so let's make this person hypoxic. He's in the upright position after 1 hour. His SATs are in the 85%. His ICP, if anything, goes down a couple of millimeters mercury. In the supine position, still looking pretty good, low SATs. After 8 hours, his ICP goes up a little bit, I guess, in the supine position, not so bad. In the upright, the supine, it's completely normal. He has no symptoms of mountain sickness. We're all feeding the same, what I told you about. Clearly, his brain blood flow is high and the brain volume is high, but he's compensated just fine. But this gentleman's Achilles heel was going to sleep that night. Now you can see his saturation went down to under, so I think like 60, 70%. You see these periodic breathing. His ICP was above 20, like 25 millimeters mercury. Brain blood flow is now much higher. And he woke up incredibly sick, feeling nauseated, feeling sick, a really bad headache. But we measured him another few hours later. He woke up. He said, yeah, I feel rubbish. But I convinced him to see he wanted to stay in the chamber because it's lovely in there. And look, he just started to breathe again. Breathe a lot more. Saturations went back up to normal. His ICP is completely normal again, and he had no more symptoms. So it's very a time-dependent phenomena. You cannot just relate 2 pressure measurements to the whole course of an upright measurement in the chamber. Okay, the next person. So again, similar upright and supine position. We went into hypoxia in the upright, and already his ICP is a little bit higher, so from almost 0 to 10 millimeters mercury. In 1 hour, his ICP now is 29 millimeters, 28 millimeters mercury, so very high. He's going to be in a world of pain soon, in my opinion. He already had quite a severe headache after 1 hour. We now go to 8 hours. Actually, in the upright position, it wasn't so bad. It came down a little bit, but in the supine position, still really very, very high. He went to bed that night, and his ICP didn't get any better, and we were waking him up periodically because, for the science, you want his ICP to be high because that's the point of the study. But an ICP of this level is very, very worrying. So periodically through the night, I kept waking him up. And at some point in the night, he said, I do have some lower leg paralysis. So actually, we gave him some 100% oxygen. ICP went back down to normal. Oxygen saturation 100%. Within 20 minutes, he got up and walked out of the chamber, and the study was over. So again, it clearly depends on time. And he only had headaches. He didn't feel any sensations of dizziness or haze, but possibly the sleep is a big problem if you allowed someone to sleep at altitude. Okay, last subject. Saturation, 100%, low ICP. And this person I'm only going to show you in the upright position because he didn't make much of the supine position. But in the upright position, already his ICP went up to almost a mean of 10 millimeters mercury. But look at these really impressive swings in blood pressure, sympathetically mediated, I guess, changes in blood pressure. They reflected directly into the intracranial pressure. So his actually mean ICP even later on, it's not so bad, I guess. But because he's on that steep part of that curve, every time the brain volume increases, it's just translated straight into the brain, and his ICP is swinging. He also felt very, very sick. He was a really good sport because we gave him 100% oxygen. So 100% oxygen, ICP, look, all these fluctuations went away. He said, oh, I feel not so bad. Come on, let's carry on with this study. I'm good to go. I took him off the 100% oxygen within almost seconds, a minute. These fluctuations came back with the periodic breathing, changes in fluctuation. He threw up again, was sick in the chamber, and we ended the study about 9 hours or so. So I don't know whether these things relate to mountain sickness. I don't pretend to say they do, but clearly intracranial pressure is not normal all the time in all people. And I have measured it with a lumbar puncture in some other people, and it's been completely flat the whole time. So it's just super individual. And unfortunately, the only way of getting at these measurements is via these very, very invasive and technically challenging studies. Okay. So just before the end of the study, I wanted to switch gears a little bit because what I think is really, really nice is, although this ICP hypothesis is interesting, if I had to bet my money, I would go just right here on the classic arterial vasodilation, blood pressure changes causing the headaches in mountain sickness, and I'll show you why. So this is a classic relationship between brain blood flow and Lake Louise score, and everyone reports this. There's no relationship between brain blood flow and acute mountain sickness. And of course, I agree with that. But what the authors did mention, and credit to themselves because they also know this, is that brain blood flow via a transcranial Doppler or the ICA is not reflective of local dilatation of cerebral vessels in discrete areas of the brain. That's completely different. And I want to show you this. This is one of my favorite studies of all time that I found. Ray and Wolf in the early 1940s, during a weight craniotomy, they probed, prodded, electrocuted, I think, chemically stimulated all the different vessels in the brain and asked their patients to report where they felt pain when they stimulated those arteries. And look how you stimulate the right side, the pain's on the right side. You stimulate the MCA, the pain is on the frontal or on the right MCA. So it's very somatically selective, and we know the MCA dilates. This is, again, Chris Imre's work, even acutely on induction. So very similar to the acute pathology, you get a headache about here, you see the dilation of the MCA, and really this has been now done in a study just been done a few years ago, and I'm very, very jealous that I didn't get a chance to do this study, but it's really, really fantastic. They've now taken MRI, and only acutely, so 3 hours. They weren't really looking at mountain sickness. This was in patients of migraine patients, really quite hypoxic, and they really looked at all these different arteries to look how they were dilating, and look every single one, whether you're a control or a patient, dilation, the MCA, basilar artery, internal carotid, middle meningeal, et cetera, they're all dilating, and they're all dilating very early on. So this could be all you need to get a headache. You don't need to have any fancy ICP measurements. The problem is how do you isolate which vessel's causing what, and the time course, and being, from a scientific point of view, it's going to be very, very difficult, but I think that is the challenge to look forward to. And I think also this gives us perhaps one hope into getting some money for science, because you are now have an experimental model of headaches. And in migraine, also, this is not it's still a theory whether dilation causes the headaches, even in migraineurs. So perhaps this is why they got it funded and also published in Brain. So maybe if anyone's interested in scientific research, it's one way we might get some money one day. Okay, so some future research, I think, is to link these mechanisms with different levels of pain and the headache. So we can all obviously measure different arteries within the brain and the size and the shape and how they're dilating over time. We can correlate that to both the intensity of pain and the location of pain. So whether it's frontal, lateral, bilateral, pulsating, dull, for example, and you could try as best you can to look what arteries are dilating and where the pain is, but I think that's going to be incredibly difficult, but that would be a good goal. We can give classic migraine drugs or somatropam to look at where the pain is and try and reduce the sensitivity of pain and look at headache scores, etc. And one thing I'll try to impress on you is that we should really try and find some way of looking at the sensitivity of the trigeminal vascular system. I don't know how we're going to do it, but I did find this one paper. I do not know Kareem Ibrahimi, but she had a really nice study trying to find the index of trigeminal vascular sensitivity using skin blood flow on the head. And her theory was that the trigeminal nerve goes to the brain and to the face and the skin. And if you give, so a baseline, if you measure skin blood flow, of course, it's very, very low in the head. And if you give capsaicin, which is a CGRP agonist, you see a really, really big increase in blood flow. And CGRP is one of those vasodilatory molecules you see in the trigeminal vascular system. And she went a little bit further and said, okay, now if I give somatropam, what do I see? And you give capsaicin, a big increase in blood flow, and a blunted decrease in blood flow when the somatropin is on board. So perhaps it is a super big jump. I'm not too sure. And I think we can do it a little bit better also than doing this ionophoresis technique with a with a microdialysis, but maybe it might give us an indication of whether the trigeminal vascular system is getting sensitized over time. And if anyone else has a better idea, I'm willing to hear it. So this is just acknowledgement for all the people who took part in the studies in Dallas, and of course all the funding that paid for it. Thank you very much.